So when we think about this idea of understanding the issues of medical malpractice and risk, this is something that if you're ever sued, likely you'll be sued based on some issue of medical malpractice. I like to do this because I think it provides sometimes comfort to providers, um, because it lets them know kind of like, where your culpability may rest. But it also helps you to navigate this system to know what you need to do to avoid this kind of stuff, right? So let's go through the tenets. So there are four major tenets, and then you'll see two things at the bottom that really are kind of these implied components when it comes to the law itself. So the first thing when it comes to malpractice or negligence is the idea of duty. Duty is about the existence of a standard of care, meaning, if the provider did exactly, excuse me, if there's a presentation of something that should be done in a clinical situation, right? So, did the provider follow the rules, right? The rules, as stated, could be guidelines, clinically recommended guidelines, they could be health policies, they could be hospital policies, so on and so forth. Then you have a breach of duty. What a breach of duty really tells us is, did the physician, in this case provider, fail to meet the required standard of care? So how did you deviate from what you were supposed to do as it regards to your duty? Then secondly, you have to have causation. Causation is a difficult thing to talk about because ultimately what you want to be able to see is that, did your direct breach of duty or some level of action cause some kind of injury or death, is what you see in the next slide, on the next line. So you want to be able to have direct causation. It cannot, absolutely positively cannot be an indirect causation and still allow the tenets of medical malpractice to stand. And then finally, within the core tenets of medical malpractice, you have to have what they call injury or death. Um, when we deal in certain worlds, poor or rude service, unfortunately, hurt feelings is not injury or death, and it's not often proven, right? So you have to have some kind of injury, something we can point that this is what the doctor was supposed to do, duty. This is what the doctor did, breach of duty. This is what that breach of duty caused, causation. And from that, the consequence was this injury, paralysis, so on and so forth, and or death. And with that, what we're trying to understand is, how that chain works. If you can prove every element of that chain, what we know is that that is medical malpractice. Unfortunately, though, many people believe that negligence is all you need. Negligence, unfortunately, is not enough. When we think about the law, negligence is not enough. Just simply saying that you messed up, that's not enough to actually convict somebody of medical malpractice. But also, Miller and Houghton, in their health law book, talk quite a bit about this idea of the fifth element. And I think this is really so important. And fifth element really refers to what we talked about in the previous slide of standing, right? The person must be willing to sue if you are convicted or have experienced, if you think you've experienced some element of medical malpractice. So a lot of people try to sue on behalf of people, which you can't. You have to have the person who was suffering some level of injustice, they have to bring the suit. Okay? Uh, the thing that you have to think about with medical malpractice and experts, let me tell you, one of the things I very much so hope for you all is that you can find your niche in this area. You can charge a heck of a lot of money to be an expert for malpractice issues, and particularly nursing process and things like that. Oh my gracious, there's so much you can talk about and so much you can do. Generally, expert witnesses are always required in any kind of med mal case. And what it often comes down to, outside of the injury or the death, or showing shocking photos and going over duty and breach of duty and all that stuff, who tells that narrative? This is a battle of the experts. You have the local versus national standards of care. You have, certain times in certain populations, there are going to be certain folks that say, oh, this is what should be done. And then they come in with a national standard and say, well, no, this is what I think should be done. And locality is often the rule, right? So what you want to remember by that is that where you are when you're bringing this case matters, right? And so a lot of times experts are able to tap into this issue of like historic problems, if you will, at, let's say, Johns Hopkins University as it regards to misdeeds of investigative, medicine or practices of medicine. Are there historic is there historic presence of unfair treatment toward patients? You know, if it's a conspiracy of silence, those kinds of things matter. Um, it also often, when you have this local kind of approach to a medical malpractice situation, it fails to recognize kind of the nationalized way we approach medicine. What we do in Washington State for pneumonia is the same as probably what they do in Florida, as what they do in North Carolina, Texas, New York, so on and so forth. And what happens is often your experts will kind of try to stick to this kind of rule of locality, if that makes sense. So what I'm saying to you is that sometimes experts drill down so deeply into whatever community that they're in that often they fail to recognize the nationalization of what we approach to be a practice or standard or duty of care in medicine. And that's problematic. But, again, there are two different perspectives. From the other side, national experts, right? These are going to be people that tap into this idea of literature and always, telling us what the researchers have said and all those kinds of things, what professional organizations believe, the American Medical Association, National Nursing Association. These are all things where folks are now able to galvanize a community of people who are considered to be the trendsetters of the field, right? They provide, in a lot of ways, the local standards, right? And that's what literature is all about. That's why I think research is so important. And even as practitioners, if you never go into research, it's extremely important that you really understand how research happens, because a lot of times we adopt things that come out of studies, and you may not know that it was not the greatest science, or it may not be specifically as applicable in certain areas. So that's something to always keep in mind. So just make sure that you try to keep your pulse on things like that. So outside of that, the other thing that we have to think about when it comes to having a case, let's say with no experts. Now watch this. No experts. What does this mean? So oftentimes some folk will try and be let's say they'll be a little cheap and not bring experts to the table. And based on that, guess what happens? You have to rest and rule based on this idea of common knowledge, right? The common knowledge exception. And this is really simple, right? Like if you have surgery and, I leave my phone in the patient's stomach, I don't really need an expert to tell me that's bad. That's that. You don't need an expert for that. But a lot of times we try to understand and or assume the ideas and instances of common knowledge. And let's just say maybe a test question could be something like, the idea of saying we had a patient that had prostate cancer, and with this patient who had prostate cancer, they were treated improperly. And we all know, quote unquote, that when you have prostate cancer, the doctors should be performing certain kinds of radiation treatment and these kinds of things, but the attorneys provide absolutely positively no expert testimony. That's going to be a common knowledge fallacy, right? That's going to be an issue where we don't all know that, right? And, what we know that to be is this idea of being able to prove negligence and causation in the Latin terms of the law is noted as res ipsa loquitur, okay? Res ipsa loquitur. So the thing that you have to remember is you have to prove negligence and causation, and you can't just rest that thing on saying, oh, we all know that when you have cancer, you're supposed to get a radiation treatment. You may kind of, sort of, maybe, hint, see a question just like what I said. on the test. And that we're going to talk about a couple of these issues within that one question. So hint, hint, hint. All right. So obviously we're not taking a coffee break. You can take a break when you want to. So the next phase that we'll focus on is this idea of policy formation, right? So Longest talks quite a bit about this idea of policy formation. And much of the readings that I tried to give you substantively really address this idea broadly about how do we deal with creating policy and getting it there and getting it where it needs to be. Well, it rests on this idea of agenda setting. It begins there, and I promise you it ends there. If the agenda's not there, we've got to do a lot of hard work. We've got to do a lot of hard work. So the thing that I want you to think about is that in order for the agenda setting frame or environment to happen, you have to have a problem, obviously. You have to present possible solutions, and then from there provide political circumstances in order to make that happen. You can have a problem, you can have possible solutions, and it be hung up in this idea of not having the political capital in order to get that to be placed on the policy agenda. From that, then you have the points of analysis, right, of policy analysis. Some of the things that you want to always understand is understanding the problem or issue. We want you to always be framing the policy or issue, knowing every angle, every perspective of the facts. You want to consider the solutions. You want to consider what alternatives are there. You want to do everything you can before you make that actual recommendation. And this is going to actually happen through kind of a process that was adopted, and it was talked about somewhat in Longest, but it was adopted from the Weimer and Vining '05 book. And that's actually a book that I think would be great for folks in the health policy world. But again, Longest really has a lock on this environment right now. But that's a very good book to kind of get you into this realm. So what they talk about is understanding or defining the problem. Same kind of sort of agenda setting, but it takes you a little bit deeper. Then from there, you want to be able to choose and assess the relevant goals, right? Choose and assess relevant goals. So you want to make sure that you got a problem, yes, but all right, so what? What do we want to do? What are we trying to get out of this problem? What are we trying to fix in this problem? Sometimes when we approach this idea of even what we're doing with healthcare reform, when we just say healthcare reform, we assume we're fixing everything from cost to access to compensation and all these kinds of things. Listen, sometimes you have to just address the fact that I'm only going to be able to talk about maybe access, or only going to be able to talk about cost, or, so on and so forth. So how you do that is about specifying alternatives. It's about, I always call it the inner 2-year-old, and I fundamentally believe in this. You probably heard me say this quite a bit, but the inner 2-year-old should always rest and reign as a researcher, as a professional. You should always be asking why. Okay, if I do that, then what, right? So you choose the impact categories, right? So you want to make sure that you choose exactly all right, where am I going from here? What categories, what things, what buckets thematically will I actually be focusing on? Concretely specify policy alternatives. Don't just come up with a solution and say, all right, that's it, that's good enough. Think about what other alternatives exist. Think about that. Think about what other alternatives you may need to create. And one other thing that I think is so important is valuing the impact of alternatives. A lot of times we get so blindsided by the ideas of what we're doing and what we came up with that we just simply don't think it matters. That whatever alternative that is out there, you're like, well, it's not my idea, so I don't think it's important. We shut ourselves down sometimes. And I want you to really make sure you think about that. Evaluating and recommending. So from that, once you do all of those things, you got to evaluate each angle that you've analyzed, and from that, you got to make a recommendation. Know your name rests on that recommendation. So let's talk about policy implementation. And again, you see my inner 2-year-old there. And I just love little kids and doing kid stuff. So this is perfect when we start thinking about the ideal policy implementation. So many of you have heard, and when you asked about particularly the uh, fact sheets that you did, you're like, well, what kind of perspective should it be? Well, there are three kinds of perspectives. And this is something that we'll address once we start actually working on the project in class for the city of Denver and the Penn Transplant House. You know, the kinds of data information that you really want, they're going to come from three different perspectives, and that's the way you present them. You're going to, if you want to be descriptive information, it's purely factual information. All you're doing is presenting the statistics. The normative information combines factual information with values of the community based on some type of community societal comparative. So again, normative is about comparing, those with the high school education compared to those without. Normative is about comparing men to women. It's about making some type of comparison, insured versus uninsured, so people have really a calibrated way to approach it. The prescriptive information identifies specific courses of action or recommendations which may abate these problems or issues. So prescriptive is purely coming in and saying, this is the issue and this is what I think can fix it, right? You're coming right in with the solution, right? There's no equivocation. You're just saying, this is what I think should happen. So from this, what we understand this to be is that analyzing public policy environments, and this is all about the longest approach. Longest really addresses how you analyze public policy through 5 different ways. Okay, and we'll go through these ways a little bit. You can jot your notes down, but this is coming straight from the book, and these are things that that you definitely read through the book, and I'd be happy to engage in more conversation on next week for your review. But I think it's very important that you understand how you approach the analyzation of public policy starts with scanning, right? Scanning is really a thing where we have to kind of stand back a little bit and figure out exactly what is out there, right? You want to be able to truly assess like this idea of what things are already going on. So the thing I think that's so important here is really this idea of being able to, if you will, scan the public policy environments, right? You want to be able to know what's going on. And this all is in chapter 10 of the most recent edition of Longest. But this is really about, how do you survey the public policy environment? Like, what's going on? And then from that, you're doing what he talks about on page 304 as monitoring this environment. What's going on? You want to make sure that you have metrics that tell us, exactly what's happening. Healthcare, as he says, the healthcare professionals should monitor the public policy information they believe to be important. So you've got to really spend some time looking at those very numbers. You can't look in one source. You need to, that's why scanning is important. You got to make sure you're going to different resources, making sure that the numbers are all adding up. From those numbers, you want to put yourself in a position to be able to forecast. And forecasting information is about, the ability to be successful, in my opinion, as a professional, is always about being able to see around corners, if you will, theoretically. Being able to know what the next problem may be so you can have a solution for it, knowing what's coming down the pipe, that's important. And that forecasting issue is really, really an interesting piece. And then from that, you need to be able to assess, largely what solutions are out there and assess the impacts that things will have on specific groups of people, on specific entities, organizations, so on and so forth. But then largely what we end up doing a lot, and this is a lot more than people realize, is diffusing different situations as it regards to policy, right? And I mean, again, we're seeing this even now, like when certain proposed pieces of legislation come out, a lot of it is about diffusing certain issues, right? Trying to get people calm because folks want to see what you're doing. They want to know how it's being done, so on and so forth. We've got to calm them down, right? We've got to say, listen, this is why this is happening. This is why this part is needed. I know it doesn't look good, to kick 24 million people off of health insurance. However, this is being done so that we can save money. So you saw the cost savings certainly increase. So there are different ways to always spend stuff, but you're really about the diffusion element is always there. So let's talk about policy modification. So I believe it was the Rothman article where we started talking about healthcare reform, and I'm much to do. I did a lot with this the day we covered Ronald Reagan in the Operation Coffee Cup. But one of the things that you have to know is that where we are when it comes to health reform has not changed. Right? Healthcare reform, it should be sometimes health insurance reform. I mean, we're all over the place with this stuff. And the thing I want you to be confident about is to know that we're always going to be stuck within this pendulum of like, should we take care of everybody or should we take care of some? And that's really the approach that we have to really wrestle with. The history of attempts for nationalized healthcare insurance, it began well before the passage of the ACA, and it's going to go on well after whatever happens with this next proposed reform. It tracks back to the Roosevelt administration in the first decade of the 19th century. Roosevelt used national health insurance reform as his primary campaign platform. In 1912, he was blasted, soundly defeated. And a large reason why he was soundly defeated was because of the American Association of Labor legislation. They led an initiative that ultimately mandated coverage for the working class and poor Americans, but it just failed. It really failed. The proposal was initially supported by the American Medical Association, but guess what? By the time 1917 hit, nope, they totally withdrew their support. So again, Teddy Roosevelt thought that he had everybody on his back and supporting him, and then once it got to it, some of the major lobbyist groups, they backed out. The next time you really saw some big moves and big initiatives came with FDR, with Franklin D. Roosevelt. And from there, he tackled the reform by basically playing to the emotions of people talking about our seniors, right? Roosevelt tackled this through the Social Security Act of 1935 and the National Health Act of 1939. And, unfortunately, he unsuccessfully attempted to expand insurance coverage for poor, working class, and elderly. But, politicians knew this bill wouldn't pass as it was. He tried. Now, when it came out, he tried to expand it to include poor, working class, and elderly, and it just wasn't going to happen. So what ended up happening? They just covered the elderly. Truman followed in FDR's footsteps, and Eisenhower campaigned. Now check this out. So Truman comes in and tries to do exactly what FDR did, and he got shut down. He had no congressional support. Literally, the Congress changed from FDR to Truman, and then coming from Truman to Eisenhower. Eisenhower basically said, you know what? I'm going to make defeating nationalized healthcare insurance or national health insurance, however you want to say it. I want to make defeating national health insurance the major piece of my campaign. Hint, hint, do you hear where we're going? It's the same environment, ladies and gentlemen. From that, you saw the Operation Coffee Cup that came out of this to oppose nationalized health insurance reform or national insurance reform as, socialized medicine. We listened to the tape. We listened to the fact that Ronald Reagan was thrust in the middle of this issue. JFK tried to pick up the mandate yet again, but he was assassinated. Lyndon B. Johnson comes in and says, all right, I got it. We're going to handle this. And you already know that the 1964 Civil Rights Act passed and allowed the expansion and creating Medicare and Medicaid. Going into the Clinton years, like the thing you have to remember before Clinton, there was a powerhouse figure by the name of Edward Kennedy. from the 1970s up until 2009, and Edward Kennedy was extremely influential in getting what we know to be the Affordable Care Act passed until his death. But Kennedy, he was so unsuccessful in trying to get the Health Security Act passed in 1971 because they were trying to make this expansion from Medicare or for all, I guess you can say. So one of the things I want you to remember is, and I'll get way more into this with the presidential politics lecture, but the thing I want you to really, really remember is that Jimmy Carter created, or collapsed, if you will, Medicare and Medicaid into one office because he truly believed that they were on the precipice of having nationalized health insurance. Nationalized health insurance. And then all of a sudden, everything got tanked because of some other political stuff that it could have been important, it could not have been. I don't know. But that's where we are. So Kennedy was trying and everybody else was trying, and then essentially all the political steam just kind of went out of the window when Ronald Reagan came in. So, and Ronald Reagan came in, and you see he was funded by the AMA to stop all of those, he was funded yet again to stop those attempts at what we saw to be reform to our medical care system. So let's move into Bill Clinton. Bill Clinton attempted to have the single payer push in the 90s, and that was most emblematic through Hillary Care. So we say Bill Clinton, but that was when Hillary Clinton was pushing this, right? Hillary pushed for a single payer system, but the Democratic Congress just simply wouldn't support it. So I want you to remember this now. This was not the Republicans opposing Hillary Care. Ladies and gentlemen, this was a Democratic Congress that said no. A Democratic Congress. The same format happened when the Affordable Care Act was on the table and trying to go through. The Blue Dog Democrats tanked what could have been, truly a transformative healthcare law. So just keep that in mind. So let's kind of go through some of the histories of reform and some of the things that have happened. And then from there, we'll end our notes from here. But this is some really important stuff because it helps you to understand the ideas of what actually happened. I just talked about the history of failed reform. Now let's talk about the actual reforms that happened that we've seen. Okay? Social Security Act of 1935, significant domestic social legislation enacted by Congress. It was considered to be cooperative federalism, right? Where it was a way to where we finally could do something for a specific group of people, and it emboldened the idea and expanded the idea of healthcare coverage for mothers, children, and old people, right? The Hill-Burton Act of 1942. Hill-Burton was a federal state program which federally funded but provided state matching dollars for hospital planning and construction to overcome hospital shortages, particularly in rural areas. Very important. Medicare-Medicaid Act of 1965, along with the Social Security Amendment of 1965 under President Lyndon Johnson. This was something that, again, established Medicare and Medicaid, but it also gave leverage to really setting up a totally different system. Can you imagine the stuff that we're going through now today, right? With the passage of the Affordable Care Act, and everybody's like, oh my gosh, I can't believe this. I don't like the law. It's an infringement on my rights. You got libertarians upset. You have liberals upset. You have everybody upset from all pendulums of the light of society. However, can you imagine in 1965 what was going on when Medicare and Medicaid came in? And now all of a sudden people started looking at their check and Medicare and Medicaid is like a tax on their check, right? I mean, can you imagine? Like, think about the climate we're in today. Can you imagine that then going on during the times of civil rights and all that other stuff? We'll talk about that in the presidential politics lecture. Then Bill Clinton's healthcare plan, 1993, it did pass. Wasn't the big, massive expansion that he wanted, but it increased access to care, and it really did a good job of decreasing the rapid increase of medical expenditures. But also what came out of the Clinton administration was the CHIP program in 1997, the Children's Health Insurance Program. It was the largest expansion of taxpayer-funded health insurance coverage for children in the United States. Very, very important because it helped particularly a lot of poor children and children suffering with chronic diseases. And then lastly, we look at the Medicare Modernization Act in 2003 under George W. Bush. And this was very big for particularly prescription drugs. As I don't know if you all realize, right around the early 2000s, prescription drug costs were going through the roof. People were paying exorbitant costs because once folks started trying to get a handle on the actual cost of medicine, then the next issue, or excuse me, on the cost of medical care, then the next issue became the cost of medicine. So this was introduced in 2003, and it kind of came out of this National Health Insurance Act, and it changed and transformed into the National Care Act in 2009. But the thing that I want you to remember about this is that the Medicare Modernization Act of 2003 was very huge in lowering the cost of prescriptions for those who are elderly, right? And that's where you see the Medicare Part D expansion and things like that. That's the thing. It's about the donut hole. And that's something that, you know, we touch around, but that was a very big deal in really trying to stabilize the cost of medicine.